Hypertrophic cardiomyopathy is a common and frequently inherited disease, characterized by thickening of the left ventricular myocardium with an estimated prevalence of 1 in 500. HCM is a major cause of morbidity and mortality, including exertional symptoms, heart failure, atrial fibrillation, stroke, and ventricular arrhythmias, potentially resulting in sudden cardiac arrest or death. The clinical practice update from the Canadian Cardiovascular Society is the first such effort from the CCS to address the management of patients with HCM. The diagnosis of HCM is contingent on the identification of left ventricular hypertrophy by cardiac imaging in the absence of another etiology that could account for this finding. In adults greater than 15 millimeters wall thickness or 13 millimeters in the presence of either family history of HCM and or a likely pathogenic genetic variant causing HCM. The diagnosis of HCM can be sometimes considered in cases of milder LV wall thickening after expert evaluation, such as an apical HCM, with associated marked T-wave inversions on the ECG precordially, or in end-stage or so-called burnt-out HCM with LV dysfunction. Some patients may present with a phenotype that is similar or even identical to HCM due to acquired conditions or rare genetic diseases that may cause LV wall thickening, sometimes with subtle extracardiac anomalies. It is imperative for clinicians to be aware of these mimics, as accurate diagnosis may impact treatment, for example, enzyme therapy in Fabry disease. Left ventricular hypertrophy in the presence of hypertension may lead to diagnostic ambiguity. Hypertension does not usually cause severe LVH greater than 18 millimeters, for example, and tends to be concentric. More advanced diastolic dysfunction and LV hypertrophy out of proportion to the clinical hypertension severity should raise the possibility of HCM. Genetic testing for patients with HCM is important. Historically, HCM has been regarded as an autosomal dominant condition caused by a single rare variant in genes coding for the cardiac contractile apparatus called the sarcomere. In recent years, it has become increasingly recognized that in most adult cases, about 70%, HCM is not caused by a single rare variant, but a combination of genetic variants that each only modestly increase risk of HCM. Genetic testing helps identify pathogenic genetic variants and to inform family screening when the genetic cause of a disease is found. There is limited evidence linking long-term outcomes to specific genetic variants for HCM, apart from the early onset of disease and worse outcomes for individuals found to carry a disease-causing genetic variant. Genetic testing should be offered to all individuals with a clinical diagnosis of HCM, although the likelihood of identifying a genetic cause of disease differs based on clinical factors and phenotypes. Genetic testing may lead to the following results: informative, i.e. a disease-causing pathogenic or likely pathogenic genetic variant is identified. It's inconclusive, a so-called variant of unknown significance is identified, or negative if there's no variant or only likely a benign variant identified. Regarding genetic testing for HCM, we should keep in mind that genetic variant interpretation is complex and should be interpreted by healthcare professionals with an expertise in genetics and with access to counseling. Genetic testing must start with an affected individual. Genetic testing is not recommended for unaffected family members unless a genetic cause has been identified in the family. For individuals with HCM where no genetic cause is identified, updates to genetic panels or technology should be reviewed every 3 to 5 years, especially with families with multiple affected individuals. Universal repeat testing is, however, not recommended, considering its low yield. So to summarize, here are some practical points from the HCM clinical practice updates. Genetic testing should be offered to all individuals with a clinical diagnosis of HCM to exclude rare genetic diseases that mimic HCM and to facilitate family screening. In families where a likely pathogenic genetic variant has been identified, counseling and genetic testing should be offered to all relatives, regardless of age. In terms of clinical screening, first-degree relatives of patients with a clinical diagnosis of HCM should generally have baseline clinical screening with echocardiography and a resting ECG. In families where a likely pathogenic variant has been identified, relatives that do not carry the variant can be discharged from follow-up if they have normal baseline clinical screening. Periodic clinical screening should be offered to carriers of likely pathogenic genetic variants and to first-degree relatives of genetic elusive HCM cases, example where a likely pathogenic variant has not been identified. Clinical screening should be individualized. The yield of clinical screening in families with genotype elusive HCM, especially if HCM is mild and diagnosed at an old age in a single relative, is likely to be relatively low.